Class, welcome to the lecture on Chapter 8, Adult Language Disorders. Before we begin the body of this lecture, if we were sitting in a physical classroom on campus, you would have walked in to see that I had 6 terms written on the board. So, since I do not have a physical whiteboard behind me to do that with, I'm going to ask that you either get an actual piece of paper and pencil or that you open up a document on your computer and write these 6 terms. Leaving, if you're using a physical piece of paper, please leave some space between each of them so that you can write some additional information later in the lecture. So these 6 terms are behavioral symptoms or behavior areas of behavior that we look for symptoms within when we're doing differential diagnosis of adult disorders. So the first one is fluency. Now, this is not the same fluency because, in English, we like to use terms over and over again. This is not the same fluency as we talked about in the chapter on stuttering. So just write the term fluency. We'll define it more later. The second is motor output. The third is language comprehension. The fourth is repetition. The fifth is naming. And the sixth is reading and writing. So I'm going to go through them again, just so you hear them again. 1, fluency. 2, motor output. 3, language comprehension. 4, repetition. 5, naming. And 6, reading and writing. Okay, we're going to come back to those throughout this lecture, this video, and into either the next video or the in-class lecture. So Chapter 8, Adult Language Disorders. The first definition that we need to go over, the first term, is the term aphasia. I'm going to read you this definition of aphasia. We're going to break it apart into its components in a little bit, but we're going to talk about it first for a moment. Aphasia is a language disorder that is acquired sometime after an individual has developed language competence. It is the result from some injury or disease process to the left cerebral hemisphere. The injury is in the language centers of the brain. Okay, we're going to come back and break that apart in a little bit. The most common cause of aphasia is stroke or cerebrovascular accident. So you'll see the acronym CVA, and that's cerebrovascular accident, just the medical term for what we typically call stroke. Although aphasias can be caused by other things, such as the infectious disease processes like meningitis or encephalitis, can be caused by brain tumors in those language centers of the brain, exposure to toxins or poisons, hydrocephalus, which is fluid buildup on the brain, or within the brain. And it could also be caused by nutritional or metabolic disorders. But all of those things would have to be impacting the left cerebral hemisphere, the language centers within the brain. Aphasia is not limited to problems of just spoken language, but it also affects written language, so reading and writing. The damage to the central nervous system is specifically defined as an interruption in the language dominant hemisphere of the brain. So, a comprehensive definition of aphasia, and this is where we're breaking that definition apart, has to contain 3 parts. 1, there must be a disturbance within the language system after language has been established or learned. So, this is not a developmental issue, right? Because developmental means it's present at the time of birth. But this is also after language has been learned. So there's some competence with language, and now there is some kind of injury or insult or disease process impacting it. The second requirement is that it does result from neurological injury or disease process to the language dominant hemisphere of the brain. Notice this time it didn't say left hemisphere. It is almost always the left hemisphere. It is such a tiny percentage of people that would have a right hemisphere dominance for language that we rarely even ever talk about it. But in a strict definition, the neurological injury would be to the language dominant hemisphere. almost always the left. The third requirement is that there must be disturbances of receptive and or expressive ability for spoken and or written language. So it is going to impact language either receptively, expressively, or both, and will impact spoken and or written language or both. Now we're always going to say spoken language throughout this, but just understand that if this is a person who uses nonverbal communication, so someone who signs, a stroke is not going to spare sign language, although there is some other area of the brain that the damage might result in within the left hemisphere. It's still within that left hemisphere and language centers. The symptoms are hugely variable based on the site of injury within that left hemisphere, as well as premorbid factors. Premorbid means what was the person's condition and what were their abilities before the incident. So we always have to take that in mind when we're doing our assessment in terms of an adult disorder, someone new on the hospital floor or in a rehab center that we're doing assessment on. Our case history is going to be very important. Also, our chart review. So looking back through this person's medical history within their chart, their developmental histories, because we need to know what their abilities were before this incident happened so that we're not attributing some of the language and speech issues we see to this incident when they may have been present previously. Aphasia is not a psychiatric disorder, although in its symptom mix, it sometimes resembles a psychiatric disorder. It is not a motor speech disorder. It is a language-based disorder, although it can coexist with a motor speech disorder. So consider for a moment, if we know that the damage is in Broca's area of the left hemisphere, right, the frontal lobe of the left hemisphere, we know that controls the fine motor control for speech. So if that's where the neurological damage is, we are probably going to have comorbid disorders or coexistence, a motor speech disorder along with some type of aphasia, and we'll get to the types of aphasia in a bit. Just some numbers for you on prevalence and incidence. The National Stroke Association does research on this every year and says that a stroke occurs within the United States about every 40 seconds. Every year, about 795,000 people will suffer a stroke, either a first incident stroke or this will be their second or their third stroke, but overall about 795,000 people. There are two basic types of stroke or cerebrovascular accident. Excuse me. If I say cardio now and then, please throw that out. It's cerebrovascular. I don't know why that just comes off my tongue easier. The first type of stroke is an ischemic stroke, ISCHEMIC, ischemic. And this is when blood supply to the brain is limited because of an occlusion or a blockage in an artery. There are two types of ischemic strokes. The first type is a thrombosis. This is where plaque builds up within an artery and eventually a blockage occurs. And the second type of ischemic stroke is an embolism. This is when a piece of plaque breaks off and migrates from a larger to a smaller artery and blocks the flow of blood there. The term ischemia does refer specifically to a disruption in the blood supply to the brain. Ischemic strokes account for approximately 87% of strokes in the United States, so it's by far the most common type of stroke. The second type is hemorrhagic strokes, and this is where a blood vessel or an artery ruptures and there is excessive blood that enters the brain. We're going to look at a few risk factors for stroke. Some of these are uncontrollable. So let's look at those first. Age. The older we get, the more at risk we are for having a stroke. Gender. are more at risk for having a stroke. Some races or ethnicities have a much higher risk of having a stroke. And then family history. So, again, this is something that we see runs in families. Now, is that because of other factors that could be controlled? Maybe, but you can't control your family history. So, we do look for that information. So, what are the controllable factors that contribute to smokes? Well, one is hypertension or high blood pressure. Certainly, well, let me go through the list here first. Hypertension, diabetes, tobacco use, and alcohol use. So you can see those are all very related. Usually, hypertension, diabetes, even though those can be genetic, they can be, I'm going to take the word genetic out of there. They can, again, be things that run in families. They are also things that can be controlled either by medication or by lifestyle changes. So, looking at weight, looking at levels of stress and anxiety, looking at amount of sugar and carb intakes. Those all contribute to those two disease processes, right? The hypertension and diabetes. And then there's tobacco use and alcohol use. And we all know the risk factors for both of those, but increased tobacco use increases the risk for stroke. Same with increased alcohol use. In your book on page 245, table 8.1, I am not going to read all of this to you. You are literate adults, but I do want you to please know this vocabulary. So again, page 245, table 8.1. This is important vocabulary. We're going to cover it in different places throughout either this video or the following parts of the lecture. But just know that this chart is a really handy place to go and find definitions for terms all in one spot. So that's why I wanted to highlight it to you. Okay, so back to our term aphasia. Aphasia is a very broad term that indicates any of a number of language disturbances that follow neurological insult or injury. So we have to find a way to classify the aphasias. Now remember, it's always left side and within the language centers of the brain, but it can present itself in very different ways, a number of different language disturbances. So the way we're going to classify the aphasias is based on taxonomy, at least for this part. Taxonomy is a combination of location of injury and what are the symptoms we see out of damage to that location within the brain. So this is where we're coming back to those 6 terms I had you write down before. Now we're going to go through these behavioral symptoms of aphasias, and I'll explain what each of them are and why they are important to be included in a comprehensive assessment. We have to look at each of these 6 behavioral areas in a comprehensive assessment. They are going to help us make a differential diagnosis between the different types of aphasias. So the first one is fluency. And again, this is not stuttering. That's not what we're talking about. It's not how it presents itself. I'm sorry, English is so weird, and we're using this synonym for the word fluency. Fluency is still the ongoing flow of speech, easy, relaxed, ongoing flow of speech. However, when it is when we're talking about it being non-fluent as part of an aphasia, we are not talking about stuttering. Non-fluent aphasias are short, choppy phrases, the use of slow, labored speech production, not blocks, not prolongations, just labored in that I can't, I'm not putting my tongue in the right place. I'm not moving my articulators correctly. It's hard work to get these words out, but not in the same sense as stuttering. It can also, non-fluent aphasias also present with grammatical errors in their expressive speech, very kind of telegraphic quality. In other words, they may drop small, less important words. Dropping it like you would, I know this is like ancient history to you guys, but in sending a telegram, you would drop out the small words, the, is, and, am, and just put the major content words. And sometimes with our non-fluent people with aphasia, they have a very telegraphic quality to their expression. It is this non-fluent aphasia is typically an injury in the anterior portion of the brain, so the frontal lobe. Okay, the damage is in that frontal lobe. The second type of fluency symptom that we're looking at, so we're still on number 1, fluency, are the fluent aphasias. These are also sometimes called sensory aphasia. This is when speech flows well. There's a nice ongoing flow to speech, adequate phrase length, but the content is affected. It might even be nonsensical, but speech is coming out nice and smoothly. This is typically due to injuries in the posterior portion of the brain, so the temporal and parietal regions of the brain. Okay, the second behavioral symptom then is motor output. So we're going to look at the person's motor abilities. How well do they seem to be motor planning for those fine motor movements required for speech? So especially in the non-fluent aphasias, so you can see now we have an overlap of symptoms, so behavioral symptoms, the motor output is going to be compromised. So those with the injury in the anterior or the frontal lobe of the brain. So again, they're groping for speech sounds. The speech may be slow and labored. So we're going to describe motor output as a part of the behavioral observations of symptoms. The third is language comprehension. Most aphasias, the vast majority of the types of aphasia, will have some degree of compromised comprehension, but it can be anywhere from extremely mild to very profoundly disordered, depending on the site within the brain. So when comprehension is the overriding symptom, when it is the biggest presenting characteristic, the aphasia is referred to as a receptive aphasia. In other words, the disorder is in the area of receptive language. So this is mostly posterior lesions. The temporal lobe is where we have impact on comprehension. In an expressive aphasia, the comprehension is going to be relatively intact, maybe just mildly impaired. So that left frontal lobe site of lesion is where comprehension is going to be the best. And so we're going to call that an expressive aphasia because expression is going to be problematic. The fourth behavioral symptom is repetition, or the ability to repeat a stimuli. So say this after me, right? You say something and ask them to repeat it back. Repetition is an extremely important behavioral symptom in differential diagnosis or differentiating between the aphasias. On its own, if that's all we are considering, it can't differentiate anything, even between fluent or non-fluent, receptive or expressive. But it gives us details about the exact nature of the language impairment in light of those other identifying symptoms. So we're going to come back to repetition in a bit. Naming is the fifth behavioral symptom. So the ability to retrieve and produce a targeted word. In other words, I hold up a picture or I point to something and say, what is that? This is naming. Anomia. Remember, anytime something starts with A, it means without. Nomia means names or words. Anomia is the term used generally for a word-finding difficulty. It doesn't literally have to mean without any speech at all, although that is what the word implies. But it's that word finding. I can't find. It's not the tip of the tongue moment. That's a typical characteristic of aging, actually. But it's the I really cannot find that word that we all know is in that lexicon of mine. Nearly all of the types of aphasia will have some degree of word finding difficulty, and it will be the most persistent symptom even over the course of therapy, over the course of the rehabilitation, if you will. My friend Scott, if you remember that I read his little statement to you that had his stroke at age 42. Scott is well into his 50s now, but naming is still a lingering issue. Occasionally, he does get stuck on a word, meaning stuck. I can't find it, not stuck like stuttering. The type of anomia is, I gotta log back in, hold on. The type of anomia is often diagnostic, so helps us, again, determine what type of aphasia. So there are two types. And again, I'm sorry, our professional lexicon gets so confusing. When we start describing the anomia, I'm sorry, did I say aphasia? I meant anomia. When we start describing it, we transfer the name to be called paraphasia. So there are two types of paraphasias. In other words, when someone is struggling to name a word and they produce some kind of name, there's two varieties. So it's a paraphasia. The first one is a phonemic paraphasia. So the substitution is either a substituted sound or a transposition of sounds within the word. So for example, if the target word is sofa, so we're holding up a picture of a sofa and saying, what is this? And the person says fossa or tofa. That's a phonemic paraphasia. They're super close, right? But they are either transposing one sound to a different position in the word or substituting in a sound that doesn't even belong there, but the rest of the word is correct. We most often see this phonemic paraphasia in a non-fluent expressive aphasia. So again, that damage is in the frontal lobe, in those motor control regions, where we have expressive language, and that's the type of paraphasia we would most often see there. The second type of paraphasia, remember we're all still under naming, the second type is a semantic paraphasia. So what do you know about the word semantic? What does it relate to under content, form, and use, right? It relates to vocabulary. So in this paraphasia, there's often a word substitution from the same semantic category. So again, if our target is sofa, what is this? And our client says chair or furniture. We have a semantic paraphasia. They're in the right arena. They've got the category. They're giving us something that's related. We see this most often in fluent receptive aphasias. So those folks that have that damage more in the temporal lobe. Okay, then our sixth behavioral symptom is reading and writing. And we're not going to talk about this extensively right here. We'll get back to it. But reading and writing is going to parallel the verbal language deficits. So we might see the same kind of written paraphasias, or we might see the same kind of struggle with fluency of getting things out. We'll come back to reading and writing quite a bit as we break down all the different aphasia types. But for now, I'm going to stop this video and we will come back to a part 2.